It's Jimmy Cushion and my three members of my audience.
Nicole, Render, me.
And this is my presentational aid speech. And it'll be on the hypoplastic left heart syndrome and the Fontan. Causes of the hypoplastic left heart syndrome include chromosomal abnormalities, environmental exposure, genetic predisposition in families, or idiopathy. It occurs when the left side of the heart doesn't form correctly. Sometimes the aortic valve doesn't form correctly. It could be the mitral valve, the left ventricle, or the aorta itself can be dysplastic or atretic. And dysplastic means it's a very malformed, while atretic means it's not there at all. So being one of those variations of those. Occurs in the first 8 weeks of gestation. Depending on the study, it occurs between 4 out of 10,000 live births, or 1 out of 4,300, according to CDC last year. Estimated about close to 1,000 were reported last year. Compromises about 8% of the congenital heart disease at large, and there's a roughly 1-to-1 ratio between males and females, with males slightly edging out the females. Abnormalities that can also occur in conjunction with it are the diaphragmatic hernia, which is when the intestines go through the diaphragm inside the body, and bowel-cell, where the intestines come out of the body, and hydrocephalus, where there's water on the brain. This shows a picture of the normal heart versus the hypoplastic left heart syndrome. Two of the big features: the very undeveloped small left ventricle and a very small aorta. Back in the old days, back before the 80s, hypoplastic left heart syndrome was almost always fatal, with very few rare exceptions. Represented about 25% of the cardiac deaths in the neonatal period. The Norwood procedure, developed by Bill Norwood in 1982, helped change all that. It was part of a 3-stage surgery that helped the hypoplastic left heart community. Norwood procedure, generally it's done immediately after birth, up to 2 weeks after birth. If they have to extend the time out to 2 weeks, they'll use prostaglandins, or more recently indomethacin, to help keep the PGA open. The neo-aorta is constricted, the main pulmonary artery, and whatever is left of the small ascending aorta, and they also use graft material to kind of help build it up to bring it up to the proper caliber. Survival rates for the stage pairs continue to rise as the surgical techniques evolve. Also uses a modified BT shunt, which is an anastomosis around the right subclavian artery to the pulmonary branches, or a conduit from the right ventricle to the confluence of the pulmonary branch arteries. Cyanosis will occur due to the mixing of the red blood and blue blood. Survival rate for the first stage is better than 75%, and this is a procedure where the heart starts to become the systemic pump of the body. And here with this diagram, we can see two main things. One, we have the small aorta from here. We'll slice it open, we'll put in a home graft, and then we'll take the pulmonary valve and part of the trunk there and move it over here. And you can see it increases the caliber of the neo-aorta. And the second one is a Blaylock toxic shunt, because we take the pulmonary artery, we take the blood would normally go to the lungs. Once we cut that, we have to find a way, so we use the BT shunt, and it goes from the right subclavian to the right pulmonary artery. The next stage is the bidirectional Glenn shunt. This is usually performed 4 to 6 months after the first surgery. The modified BT shunt is taken down, the SVC is connected to the PE branches. It reduces the workload that the RV has to do by shunting blood from the returning body directly to the lungs, and it's about 1/3 of the venous volume or total blood volume of the body. And the third stage is the Fontan procedure. That's usually done between 18 months to 3 years old. The IVC is connected up to the pulmonary artery confluence. This brings the other 2/3 of pulmonary blood flow into the heart. The oxygen-rich and oxygen-poor blood isn't mixing anymore. Patients will need regular cardiology visits for the rest of their life because it does not cure the problem, but it helps make things better. And here we have the diagram of the Glenn shunt and two versions of the Fontan. With the Glenn shunt, we can see the BT shunt that was there. They've taken that away and they connect the FVC into the pulmonary artery. And then there's two versions of the Fontan. The lateral Fontan is an older procedure, and extracardiac Fontan is one they do more often nowadays. It takes the IVC and wraps it through, in the lateral version, through the right atrium into the pulmonary arteries. In the extracardiac one, they have a conduit that goes from here to here, and they reroute the bottom 2/3 volume of blood up into the pulmonary arteries. The reason why they've kind of gone from this to this, there used to be more arrhythmias associated when they would stitch into the right atrial tissue. Complications from the whole entire procedure: blockage of the BT shunt. If that gets blocked off, blood can't get to the lungs. Chronic diarrhea from the protein oozing entropy, which is a problem where their gut can't process food and proteins properly, so they lose nutrition. Ascites, which is just general collection of fluid in the thoracic cavity. Pleural effusion, which is fluid around the lungs. Heart failure, arrhythmias, many strokes and full-on strokes, and sudden death. In closing, this is a 3-stage procedure, which is palliation, which means it's not a cure, but it does help make it better. The child's circulation is made to work with only 2 of the 4 heart chambers that it's supposed to have. Patients now are in their 30s, and the long-term prognosis is unknown. Advances in surgical and medical techniques have helped increase the survival rate, and sonographers like myself and others play an integral and organic role in the management of these patients. And that'd be my opinion. I'm finished with the speech.